Thank you so much for joining me, Mia.
Thank you, Megan. And I'm also a whole mama now, so that's fun.
Oh, you are. So like Brandon said, happy Mother's Day early. So I would love to kind of steer this conversation in kind of 3 parts. I heard the Congresswoman say yesterday, all of us stand on the shoulders of someone else. And if you've ever been into the Congresswoman's office, she has a picture of Shirley Chisholm, Congresswoman Shirley Chisholm in her office. And, thinking about now being the new Senior Health Policy Advisor, I know I stand on your shoulders as you were, very vital and instrumental of introducing the MOMMA'S Act in 2015. So I just want to take the time to kind of go through memory lane with mamas and then talk about like what has happened with it, all the good movement that has occurred and what has been enacted to law. We are currently working on what I've just been affectionately been calling Mamas 2.0 about, that's the thing about when legislation passes, right? You have room to add new pieces of legislation and then kind of like what additional steps do we really need to think about? So I want to turn it over to you to kind of start and talk about why did you start looking into maternal health and what was the crux of even going down this journey of looking into this piece of legislation?
I'm so glad to be doing this on just before Mother's Day in particular. And also, I'm so excited to be here as you're fulfilling your current capacity, Megan. It's such a pleasure. I appreciate also the parallel that you drew in terms of each one of us standing on the shoulders of others, right? That really makes the work of the Congresswoman even more meaningful, because this is legacy work, but I'm also quite clear, especially with respect to the MOMMA'S Act, that this is work that will essentially save lives, and the lives that aren't yet here, or the lives that are here, people who are yet to become mothers. And I'm so very proud historically that you and I are intersecting at this particular moment. So what, you asked me, what initially spurred the really the force behind the Mothers and Offspring Mortality and Morbidity Act. That's the MOMMA'S Act, MOMMA. And so in 2016, I joined the Congresswoman's office as her health policy fellow, as you mentioned in my bio. And at the time, I was speaking of standing on shoulders of giants, I was the health policy fellow named after historically that fellowship is named after Louis Stokes, who for many people in the virtual world already know, but others don't. Louis Stokes was the co-founder of the Congressional Black Caucus in 1952, if I'm not mistaken, amongst about 14 other people, including Shirley Chisholm. And but he was also the founder of the Congressional Black Caucus Health Braintrust. And under the Braintrust, as Megan mentioned, members of the Congressional Black Caucus were, and beyond, looked to the CBC for specific guidance around certain health issues that they were then raised in policy. And so Mr. Stokes passed that mantle on to Congresswoman Delegate Donna Christensen, who used to represent the U.S. Virgin Islands and the territories. She then passed it on to Congresswoman Kelly when Congresswoman Kelly came in office in 2013. I have joined the Congresswoman's office 3 years later as her fellow, and it was just an incredible time. I was supposed to be there for 2 years as her fellow. She ended up hiring me about 6 months into my fellowship. And at that time, we were in the minority. I'm not even going to take the time to talk about what 2016 looked like, right? Because politically, it was quite a transformational year for so many people, and well, really for the world. And so at the time, going into the next year, 2017, we were doing a lot through the Braintrust, right? A lot around clinical trials. We were doing a lot around dental health, but we were also still in the minority. And what that means politically is that not necessarily, generally, the minority party doesn't necessarily expect to pass a lot of really big legislation. But one thing that happened that year, we started, the Congresswoman and I, just receiving stories. People would come up to the Congresswoman, certainly because of her role as the Health Braintrust chair, but also just given her warmth and her effervescence. They would come up and talk to her about different things. And so one of the stories that someone shared with the Congresswoman was a story of Kira Johnson. And Kira Johnson is the daughter of a name that many of you would recognize, Judge Hatchett, Judge Glenda Hatchett. And Judge Glenda Hatchett's son was Charles, was married to Kira Johnson. Kira was the picture of health. Mid-30s, mid to late 30s, Black woman, similar to my age. She was a polyglot, which meant she spoke more than one language, multiple languages. She would race cars. She jumped out of airplanes. She lived all over the world. She had a baby boy already, and she was pregnant, she and Charles, with their second. And Judge Hatchett shared with the Congresswoman that upon giving birth via C-section to her second son, Kira bled out about 12 hours after giving birth to her second son, and she never saw him grow up. And it was due to a cut that severed a main artery in her midsection. And unfortunately, the physicians didn't listen to Kira or to her family. And these were not people who were closed-mouthed people. I just told you she was the daughter-in-law of a major judge, and not just a major judge who had a major television show on a major platform, right? So when we heard that story, we were just completely taken aback and very sad for the family. And so from there, we wanted to do something to honor Kira's legacy. And so the Congresswoman and I put our heads together, and we came up with what was effectually a listening, it was a briefing, essentially a congressional briefing, but it was also a space to receive these other stories and to also tell Kira's story. And so after we did that was early 2017, the Congresswoman and I made a pledge to the family and to other families that we would do something legislatively about that. And so over the course of that Congress, we wrote what would be born as the MOMMA'S Act. And it is a 5-prong, at least at the time it was a 5-prong piece of legislation that looked at a number of things, which we didn't just pull out of thin air. We met with all kinds of people, people from March of Dimes to the National Birth Equity Collective, to Merck for Mothers, to even that woman who wrote that book on, what's it called? What to Do When You're Pregnant or something like that. Everybody has this book. I have the book, the author signed it's on my, anyway, we met with everybody. And so we eventually came up with these 5 prongs that birthed the MOMMA'S Act. And basically was, the legislation called for provisions of technical assistance for states with respect to reporting maternal mortality and maternal morbidity through standardized data collection methods. The MOMMA'S Act also called for instituting best practices for what are called MMRCs, or maternal mortality review committees. And review committees are highly significant because those are the boards that look at the data and use the data to come up with best practices for preventing maternal deaths and for also identifying deaths that are pregnancy related or postpartum related, and make sure that they are written on death certificates in the correct way. Probably the most significant part of this legislation, and you'll likely talk about this some more, Meagan, is that the MOMMA'S Act called for the expansion of Medicaid and CHIP coverage for postpartum care for new moms past 60 days, and specifically for up to a year. I am, as I mentioned, I'm a new mother. I couldn't imagine, my son's now 17 months. I couldn't imagine if I were a mother receiving Medicaid that I only had coverage for 60 days after having a child. My body would not have even healed. My body is only just recently healing, almost 18 months after giving birth. So think about that for sure. The MOMMA'S Act also at the time called for support of the Alliance for Innovation on maternal health. So, or AIMS. These are like, this alliance looks at like different data-driven practices and safety bundles that like emergency rooms would use when they're encountering women. And then finally, it called for establishment of regional centers of excellence, addressing provider training around bias and cultural competency. And so this was a big baby, basically. Birthing this legislation was no small feat. As I said, it took over a congressional season to write it and to receive and to really court different players in the space to ensure that we were being extremely thoughtful and diligent and visionaries. Because Ms. Kelly, the other thing I need to mention, and if you take nothing else from this call, the MOMMA'S Act was the first comprehensive maternal health bill in the history of Congress, in the history of all Congress. And I'm so very proud that the Congresswoman and I wrote this legislation together. I will also give credence to the first person who wrote a bill around maternal health from the great state of Washington. And she was not a member of the Democratic Party, she was a Republican. And so the Congresswoman worked alongside her Republican colleagues to also, because again, she was in the minority at that time, to raise the point. But when it comes to the first comprehensive law, it was the MOMMA'S Act, or policy was the MOMMA'S Act. And I said a lot, so I'll be quiet and turn it back over to you.
No, that was beautiful. And I think a great overview of establishing what the MOMMA'S Act is and how you got it to this point. And so, like you said, I definitely want to talk about the wins that have happened, because it's very fortunate that we've been able to get large chunks of this piece of legislation over the finish line. You shared your personal story regarding insurance coverage, right?
Yes.
MOMMA's allowed for states, MOMMA's in its original state of the Medicaid expansion from 60 days to 1 year permanent, but creating that bipartisanship, that piece was pulled out into what was affectionately known as helping moms. Yes. And we were able to get that permanently established for states to opt into passing Medicaid postpartum extension coverage from 60 days to 1 year. And we're very excited because 33 states, I believe now, have opted to do that. Missouri did it this week. And I know I sent the link to the Congresswoman and she was just yelling and just saying, "Hey, we're so excited that's getting done." And as we think about MOMMA's 2.0, one of the things that we're going to continue to do is say, every state needs to do this. So yes. One of the provisions that will stay in there is making that provision permanent for every state. They must do it. And another piece that was so vital that got across the finish line, once again, pulling out a lot of these bipartisan pieces of legislation out of the MOMMA's was the Maternal Health Quality Improvement Act. And that, you know, what you spoke about, establishing grants under HHS to help improve best practices regarding maternal care. And so, you know, MOMMA's is one of those pieces of legislation that have had
it's birthed other children.
I know, it's birthed other children. It's gotten across the finish line. Everyone's super supportive of this cause because it's one of those causes that has so much bipartisan support, right? And we can see the legs and the new children that are coming out of it. And so I think what I want to talk about is kind of like, you know, as you spoke about like the reason why you created this bill, and I think about the stories you just shared, and, you know, I think about Serena Williams.
Serena Williams, of all people. If no one was going to listen to anybody, listen, Serena does not keep her mouth closed, right? Why would no one listen to her when she said, I have a medical history of an embolism, I believe it was. And she was very clear, I don't feel well. I need for someone to look into this. It took major insistence for someone to look into that. And God forbid anything would have happened to her. And we would have been without the greatest athlete of our generation, right?
Just by listening.
Mm-hmm.
And, you know,
by listening to Black women in particular.
And that's a great segue of just like where we are today, because all the work that we've been doing, all the legislation that has been passing, the CDC comes out with a report in 2021 saying the maternal mortality rate has actually increased, you know, and I know like legislation takes some time to, you know, really be impactful, but as we are continuing to have this conversation in the national lens, like this is a crucial moment. We need to really look at the data. We need to really make sure we're implementing these policies because, and I know you know the data, but I'm gonna throw it out for the audience, 3.6 million women give birth in this country every year. And, the CDC says that right now we're at 32.9 deaths per 100,000 live births. And that has continued to increase from 23.8 in 2020, 20.1 in 29. And what that equates to, because, give it some raw numbers, is about 1,200 women dying per year just due to childbirth. And then we also learned that 84% of pregnancy-related deaths are preventable. And so it's those little things like listening when a Black woman says, I don't feel well, something is wrong. We hear the stories over and over again. Woman in Louisiana gained 9 pounds in 1 week, kept going to the provider, something is wrong, my body isn't doing well, she passes out and dies. And so these are just some of the things that I would love to talk to you about in the sense of, we always talk about the workforce, right? And making sure that we have providers that look like us,
Yes.
that understand us. But when you look at some of the data, 5% of all active physicians identify as Black. And then of that 5%, 11% are OBGYNs. And so, and once again, 3% of all doctors are Black women. So we're, as Black women look for providers to care for them, they're very few and far in between. Do you have any thoughts about ways that we can bolster and increase the workforce, especially in terms of diversity?
Yeah, so the first thing that I'll say is one shouldn't have to go to medical school to learn how to deeply listen. We learned that before kindergarten. My son is 17 months and he's learning to listen very well. In fact, he knows that if he doesn't listen, his safety is on the line, right? So he's not even been on this earth for 2 years to know that. So for any physician, or really anybody who, not even just a physician, who's a care provider, to discount the concerns of women, of families, of birthing peoples, particularly in the moment, is not only extraordinarily dangerous, but it's also, that's just basic, right? That's just basic human value, a basic human valuation process and practice, right? And so when you're talking about what are some things that we need to do, I'm going to talk about it certainly from a legislative standpoint, because that's essentially where my level of expertise comes from. And that's also where many people who are likely in the audience will think about it. Well, the number of things we need to look at. For one, from a political, I'll use my friend Daniel Dawes' terms, from a political determinants of health perspective, there needs to certainly be or people who are training to become medical providers would do well to also learn how to become powerful advocates in the policy arena, right? Because it's their voices, especially those who are current medical students and students who are going for higher education across the healthcare continuum. They need to be able to connect the dots between how things are in terms of their own schooling experience and how you can make them better. And that matters when they learn what the appropriations process is, how are monies allocated to things like residency spots, or how are monies allocated to support the building and construction of new medical schools or public health schools, or, where do you go in terms of the person to move the needle on policies that, again, not necessarily having to do with the money, that's appropriations, but authorizing programming, for new pipelines. And so that's the first thing that I'll say is, from a political standpoint, from a policy standpoint, anyone who's training to become a provider has to be able to understand the political process. And then the other thing I'll say is, for sure, investments, not just in STEM and STEAM education, obviously, right? So, and I'm talking about way before high school. And that's, again, these are bipartisan issues, just ensuring that the drumbeat is really at a steady rhythm in terms of investing in early education. And so that involves being in touch with members of Congress who are on the Labor and Ed subcommittee, or excuse me, Labor and Ed committee, or and not just solely within, having the conversation about workforce of health or health workforce within the, traditional walls of medicine. These are conversations that have to be really evaluated from intersectional lenses, from socially determinant lenses. And so, yeah, I would say start with the policy for sure. There's so many other ways you can answer this question, Meagan, but I'm going to really stick my toes, 10 toes to the ground with it starts with the policy.
No, and I love that answer because, coming with my background, I'm an RN by trade and I went into hospital operations and, many of us don't really know the policy, like how policy impacts how we provide care, and to share about how I pivoted from hospital operations and acute care here. I was having a conversation with my best friend and she wanted to, she wants to be a mom and now she is, but, at that time she said, I want to have a baby, but I don't want to die.
I literally said similar words to Ms. Kelly. I said, I'm going to have this baby and I don't want to die, but I'll actually talk about that some more. Maybe I want to hear more of what you're saying, please.
Yes. And so I looked at my best friend because in my mind, this is the safest place to give birth. What do you mean you're afraid to die? And so she said it multiple times. And then I finally looked into the issue and I was like, wow, I did not know what was going on. And I think sometimes, you've probably seen it. We are trained in our silos, right? So I was med surg, I wasn't women's health. So I know how to take care of you if you have a heart attack or have COPD, but if you come in here with a baby, that is just out of my realm. And so that really was the driving factor for me to understand policy. And I think now what you just eloquently said is, how do we target appropriations? What does that mean? What is the legislative process? Okay, we passed it, but if we're not putting money to these programs, it's pretty much non-functional. So, another piece in the workforce conversation in terms of diversifying the workforce, maybe in terms of race, is also professions, making sure, and that's one of the things we're trying to do in MOMMA'S 2.0, give more voice to the doulas and midwifery programs. And how do we make sure that they are accessible to women who want to have them? Because a lot of times what we're hearing is women want to have them, but they don't know how to access them. They don't know where to find them. They want to make sure they do know what they're doing. And so, how do we bolster those pipelines of clinicians that we didn't really think of in the past, but are a huge vital force in this sector of decreasing the maternal mortality rates? And so another component that I'll talk about regarding the workforce is more mental health providers. Looking at the statistics regarding the maternal mortality rates and how mental health is playing such a huge part, but only 3 to 4% of our workforce even looks like us, to understand us, to really have that nuanced conversation about how we're feeling, to help bring those statistics down. So I love what you said about the policy aspect as well. And, I definitely just want to make sure we're putting in plugs for the variety of workforces that we need to target, and, bringing in, our HBCUs and the different institutions, because, they are the crux of kind of like our culture. And, we need to be having these conversations like in academia, but also, when I think of our culture, I think of the church. How do we incorporate wellness into some of our programs? And so, I had something here regarding training, right? But you already spoke to that. Like, it doesn't take going to school to know how to listen.
I really liked what you just said. If you don't mind, I'd love to address 3 of the points that you just made. So the first, I'm going to work backwards in terms of the role of HBCUs. So I'm a graduate of 2 HBCUs. Cheney University is the first historically Black college and university in the nation. And I went there for undergrad, and then I went to Meharry Medical for my training in health policy. But I'm also a product of 2 PWIs, one, the whitest of the white institutions ever in Oxford, and it's all white people there. It's fascinating. And then I also attended Vanderbilt for starting my doctoral studies. And so I'm keenly aware of not just the It wasn't so much a major difference between the four in terms of the quality of education, but in terms of the quality of my attention to, I was extremely socially astute to the situations around me. In each of those scenarios, there was something bigger than the academics going on around the world. There was either a conversation around racial violence. So for instance, when I was in Vanderbilt, that's when the court decision came down for George Zimmerman with respect to the slaying of Trayvon Martin, right? And so many other conversations around these moments where I've just been in these different institutions. And all of that wears on the body. All of that informs the way, especially Black women who are highly educated, go through the world. And what we know, what the research says, and consistently shows, is women, Black women, who give birth to babies in the United States because of their experiences associated with racial stress. When they do give birth to babies, the babies tend to be, on average, lower in birth weight compared to not only white women who have never been to college, but also African women who have just recently matriculated to the United States. So it's not a matter of race. It really has to do, in a lot of ways, with the stresses associated with feelings of racism, and not even being stressed personally in terms of being the direct victim or recipient of whatever the issue is, but certainly seeing yourself in the largest situation. So when you were talking about mental health, that essentially comes to my mind as well. I gave birth to my son during height COVID, right? So I became pregnant in early 2021 and gave birth to him at the end of 2021. And so there was so much going on in the world at that time as well. COVID was a thing. People were home and not interacting with each other. Remote work was certainly the main thing. I think you'd spend a lot of your beginning time with the Congresswoman's office in a remote scenario. And then also there was a lot going on in terms of racial violence. Breonna Taylor, Ahmaud Arbery. We had just also lost the young man who was, just playing, violin and walking home. The young man who was feeding kittens and everything. He had just been died, and then, or just been shot by police. And then we were also dealing with, of course, George Floyd. So all of that happened across 2020 and 2021. And all of that was certainly wearing on my body. And then I will be a bit vulnerable here because it matters in terms of my own pregnancy story. And it matters in terms of my championship of the MOMMA'S Act. I was assaulted in 2020 and outside of my home. And it was a harrowing event. And then unfortunately, I was also assaulted while I was pregnant. And both of these scenarios were by strangers. Someone was trying to jack my car in the second scenario. But in between that time, I took a sabbatical from work. At the time I was working for the American Medical Association. I took a sabbatical because I had to make sure that emotionally I was safe, and I needed to make sure that mentally I was prepared to handle whatever issues I, presenting with. And apparently, anyway, there were just some, like I said, it was an emotionally heavy time, but I knew that in order for me to do the work that I'm called to do in the world, a part of which is to be a champion with respect to maternal health, you have to take care of yourself. You have to take care of yourself. And so when it comes to cumulative stresses on Black women's bodies, that certainly shows up in terms of our experiences with becoming mothers. And we've got to be open about it. What I just shared with you is obviously recorded into perpetuity, and that's a thing, but I don't generally share this with people because there is also this feeling of, well, what could I have done to stop a certain situation, which is not an unhelpful exercise, but it misses the point because the conversation is systemic. It's not necessarily a matter of, if you're talking about interpersonal stresses associated with racism, that's one thing. That's a one person to one person interaction. And that level of interaction can sometimes be mitigated through building relationships, right? But if you're talking about cumulative stressors, hearing stories on the news across a long period of time and social isolation, and then dealing with all other stresses associated with work or with going for a higher education, or you know, all of those situations, scenarios that you and I and many other people were experiencing, that wears on the body in a way that we don't see. And so to your point about mental health providers, I was really fortunate to be able to, I think I used a smart app to find a provider of color to help usher me through that particular period in my life. And it was a game changer for me. I didn't stay with her ultimately because in my personal experience, I knew that my situation was not chronic. It was acute, and I needed the care at that time. And so I do other things right now to ensure my own well-being. I practice hot yoga. I take many walks under canopies, and I spend a lot of time in nature. I live in a part of DC that's close to gardens and arboretum and all kinds of places. So I spend a lot of time there. I garden myself. I spend a lot of time putting my hands in the dirt, which my son loves because he loves putting his hands in the dirt. So, you know, and I keep close to my family and my loved ones, and I'm not afraid to say, I need space or I need help, right? Because I know that not only does my physical and my emotional health depend on it, but the output of my work depends on my ability to be well. And so, you know, when you're a champion of particular health policies, you've got to live the life that you're trying to create for other people.
I love that you say that you're comfortable of saying, I need space and I need help, because that is just so crucial of being emotionally intelligent enough to say when you need to step back and when you also need to seek help. But I also think, you know, we need to do a better job of making sure people know that it's okay to say these things. You know, we don't need to hold on to this. We need to find the tools to be able to deal with so many stressors, and like you alluded to, like the things that are happening to you directly, but then the things that are happening to us as a society, because all those examples you gave weighed so heavily on so many people, and it manifests itself through our health, and then unfortunately to our children when being pregnant and giving birth. And one thing I know I have been forgetting to say is, please, everyone who's on the WebEx, on the Zoom, if you have questions, please use the Q&A box to put them in, so we can also keep your questions flowing through the dialogue, since I know we're over the halfway mark. And one of the things that I love that you spoke about, which I wanted to talk about as well, is digital tools as solutions to this problem. Like, we know 2.2 million women of childbearing age live in what is known as a maternity care desert. The lower part of our district, Illinois O2, women have to drive an hour away to receive any type of care. And, you know, I know you could probably speak to, like, if you need to drive an hour away to receive care for all the appointments that you have to meet, that's cumbersome, and you probably wouldn't even do this. You know, and then and what does that equate to even more? 150 babies being born in maternity care deserts. And so, you know, when you spoke about the SMART app, and that was how you were able to receive mental health services, as we think about digital tools, right? Maybe one of the silver linings of the COVID-19 pandemic was telehealth. And I've heard the Congresswoman say that she does believe that telehealth can be a great tool at bridging the gap of health equity, but we have to make sure that people have the underlying infrastructure, right? I love how you were just talking about all the different structures that we don't think is healthcare, but it is. Broadband internet.
Yes.
That is healthcare. You know, we think about these things in different aspects, but they overall mean like care for people. And so, you know, mental health services, being able to digitally and remote monitor people's situations. When we talk about Black maternal health, we have to think about high blood pressures, right? Because of everything that's going on, to make sure they don't go into preeclampsia. And I know you work a lot in trying to bridge some of these gaps with technologies and innovation in the women's health space. And so I would love to just listen more about like what you have seen in this space regarding like telehealth and digital tools that could help us also bring down that maternal mortality rate.
For sure. I love this question. And then before I forget, if we can go back to the doula part after this question, because I forgot to say something really significant there. So in terms of the use, you hit the nail on the head there, Megan. During COVID, and it's good for the audiences to also know that parts of the MOMMA'S Act that you called out, some of those passed during COVID, right? And so that was when the nation, really legislators in a lot of ways are starting to really pay greater attention to this issue of maternal health and specifically mortality and morbidity. And what we also saw through various packages, Cures 2.0 and, the CARES Act, you saw budget lines being allocated for investments in broadband, for laws that move the needle with respect to reimbursement for telehealth care, especially as people were remaining in their homes, but still needing to present for critical care, right? And so now that's the norm, right? I'm not saying that had it not been for COVID, that would never happen. But what I am saying is that wouldn't have happened now, right? And so now we are in a space where, with respect to 21st century medicine, we've got to be able to contend with the role of non-healthcare providers of healthcare, right? In terms of being able to facilitate good care. So if you're talking about the role of smart apps, like one app that might be useful for people who are considering having a child and you're looking for providers of color, the app is called Earth, and it's developed by maybe the NMQF staff can pull this up. I'm not saying this to endorse the app itself, but I'm just spreading information about a particular tool. Tools like that, or tools like built by another woman of color called Poppy Seed. These are apps that help people to find not only resources in terms of birthing peoples to help us, assist with actual birthing, but also resources for before and after giving birth. So those are two that I would certainly assert. I would also say that when you're looking at the birthing process within a clinical environment, there are a number of research studies that are coming out now that show differing levels of impact with respect to using AI technology or artificial intelligence or autonomous intelligence to assist providers in their clinical decision-making tools. But I will say that that's not necessarily a panacea, right? Because we know historically that when you're dealing with any kind of tool in the healthcare space, historically, they've not been built with Black and brown birthing peoples in mind. I think we're starting to see a shift in terms of cognizance, and therefore a shift in terms of intention to use data to fuel the algorithmic systems of these tools, so that the output is commensurate with the unique needs of Black and brown peoples, right? But one of the most egregious tools that's touted as quite innovative, but had been, potentially harmful for Black women is the VBAC, which is based on, the VBAC is a tool that physicians and providers use when trying to decide if a woman should pursue a vaginal birth or a cesarean. And based on the score, the outcome score, the physician really generally, or usually the physician pushes that decision. And when you're talking about women who are in, splayed out, or, and not really, hormonally in a space that they're used to, you might go with whatever the decision of the provider is, and it can be stressful. So we want to make sure, and the thing about the VBAC historically, it provided a score that suggested that Black and brown women, more so than white women, should have a cesarean. That's historically what it had been, and you can look all of this up. This is not anything I'm just pulling out of the side of my neck. And the other thing I should say is I study this. So my current doctoral studies have to do at the intersection of health, equity, policy, and AI. And so These are all scenarios that theoretically I read about all the time. And then now as a mother and someone who has given birth, I think about it in a different way. What I will say that's not necessarily technology related, but I found them through the internet is I hired doulas to assist me through my entire pregnancy. I shared this at the most recent NMQF Health Summit that I hired 3 doulas to see me through. And I will say I feel very blessed that I was in a position to do that, but doulas are expensive. And it is quite a barrier for a lot of people to seek that level of support. However, we need to be able to ensure that doulas and midwives, to your earlier point, Meagan, are a part of the birthing process. And they had been historically national, in the nation, particularly in the US South, but we do know that due to all kinds of politics that have to do with policies that are built, by people who may or may not look like us at the table, at the decision table. But now we do see policies that are vying for reimbursement, for commensurate reimbursement for doulas, for midwives, and so forth. So I really look forward to Mama 2.0 to bringing that to the forefront. But yeah, I had a doula for my perinatal experience, birthing doula, and a postpartum doula, and one of them served me on both occasions. But I will say that it made the difference. It made all the difference in the world. I could not have done it without my doulas.
And that's the stories that we hear all the time. And, one of the questions that's in right now is how can one make more effective use of stories, narratives in the health policy making space? And, I think for me, and you alluded to it too, like stories are what help move us, right? When the 1,200 women dying each year doesn't resonate for you, it's that story that really helps bring the numbers home to people. And unfortunately, sometimes it takes the names, I think, that we know of and can relate to quickly for the masses, but the stories are really what helps push legislation, I think, behind the scenes. And, I can just speak for me, listening to your story, listening to so many women's stories. That's how we have built MOMMA'S 2.0, right? When people are telling us, no, I want more community-based centers to help give birth. Hearing people say, I want to give birth at home. I want midwives and doulas as part of my birthing team. And another thing that we're looking at too, based on stories, is, and you alluded to it, the research, right? Women and pregnant and lactating women are typically seen as a vulnerable population. And so during the COVID-19 pandemic, we, as vaccines were rolling out, people are like, well, can pregnant women take it? Can lactating women take it?
And they whispered it just like that. I remember
all of
that.
us who are like, I don't know. Like, what does the research show? And I think, and correct me if I'm wrong, I think we realized someone became pregnant during the study. Like, we literally tracked like 2 cases and was like, I think it's safe. But then
I was vaccinated and boosted all during my pregnancy.
See?
Yes.
And so, we had to do these real world examples. And another piece that we're trying to think through, with these stories that are told to us is, how do we incorporate pregnant and lactating women into research so we know what's safe for them, so we know what medications they can take? Because I'll give you this story. We were just thinking about oncology care. And just because you're pregnant doesn't mean the oncology and the cancer in your body takes a pause. And, depending on where you are in your pregnancy, 6 months may be too long for you to wait to receive treatment. And so, these are just little things that I think are hugely impactful in making sure the whole person is taken care of. And so, for that question, that's how we move legislation in our office from the stories, is we try to act on them as quickly as possible to make sure that the whole woman is taken care of. But I don't know if you want to give an example of stories and how you think through policy through stories.
Yeah, I mean, as a former staffer, the stories matter, right? But I will say all stories are data and all data are stories, right? So if you're talking about numbers data, it's hard for people to, as you've mentioned, it's hard for people to really understand what the numbers are. Like if I say to you 1 in 10, you can, I mean, I don't know what comes to your mind. Think about, because I have a toddler, think about Cheerios. Think about if you lay out 10 Cheerios, right, on your table, and you say to yourself, 1 in 10 of these Cheerios is going to be eaten by a toddler eventually, right? And that is inevitable. It's going to happen. It's easier for you to recognize those numbers. But if you say something like 1 in 100,000 births result in a maternal death, right? It's harder for people to really imagine 100,000, right? For a number of reasons. It's just not a number that people deal with on a regular basis. But if you say Shalonda Irving was one woman out of 100,000 who died 3 weeks after giving birth to her daughter Soleil, which is true. A woman who was a nurse out of Johns Hopkins passed away after she gave birth, and she was a researcher for NIH, I believe, on maternal health, of all things, and she died, Black woman, right? So putting a name to that one matters, but you've got to be also able to understand the numbers, because if you don't understand the numbers, then the nation's not going to listen either, and members of Congress are not going to listen, because it's almost like it takes a tipping. Miss Kelly wrote, and I wrote the MOMMA'S Act in 2017. It is only recently that now we're seeing a whole suite of all kinds of maternal health bills. Now we're seeing other members of Congress paying attention to it. Now we're seeing that, other all kinds of researchers coming up with reasons, doing the science to come up with reasons why. We're seeing national stories take off, right? It took a long time for people to really start to wrap their heads around the stories, right? But once the stories started to enumerate, then the ball started to roll. So you need both. You need the qualitative as well as the quantitative data. I do not think, and I do want to give hope to the person who put this question in the chat. I would not lose hope about members of Congress not paying attention to quote unquote health disparity numbers. People pay attention to it very, I'd say certain language might land more or less with people depending on how you present it. So if you're talking to a member of Congress who's a part of the Democratic Party, you can use, I would say, terminologies like health disparity or health equity, right? If you're talking to a member of Congress of the Republican Party and you want to convey a same message, you've got to use different language. It's all the same thing. And you might want to say the economics associated with risk to giving birth, right? That is literally the same story of health equity, inequities of birth, but couched in a way that resonates specifically with that member of Congress. And you have to be able to learn that language. You mentioned before, I speak 3 languages. I speak 3 languages because I need to know, because I was living in a space where no one understood me. So if you go into it, and I had to learn, right? Like they didn't need to learn how I talked. I need to learn how they talk. So it's the same with policies. If you're going into a space and you don't know the language, you've got to, well, rather, if you're going into a space, you've got to learn the language. And if you don't know the language, just ask someone. That's it. Yeah.
No, I love that answer. And I think it kind of alluded to a great tie-in back to where we first started regarding how do we make sure clinicians even understand policy and the languages that we use? Because, a lot of people talk about health literacy, right? And so now we need to start talking about policy literacy and how to move legislation and what are the key words and how do you change your messaging for who you're speaking to. And so I think that's a whole different webinar that we can set up on ways to train people on how to talk to your legislature. But there's another question, and it is a beautiful question because it deals with the workforce, right? To what degree does exhaustion and burnout contribute to overburdened care providers not always being able to listen appropriately to patients? What can policymakers do to address oppressive organizational system issues that unfortunately help create above problems? And that's a great question. And I think, like, coming from the other side, a lot of times clinicians are working to metrics.
Yes.
the clinicians are working to how many patients can I see in this hour?
Yeah.
Like, you know, you're saying something like, I have a headache, I have a stomach ache. What's the more logical thing? Have you slept? Have you had water today?
You had water?
And so you're like, I don't typically have headaches. I typically don't have this. And so unfortunately, because of those constraints, I think that's a lot of times what people feel and see as not being heard. And I'll do an example. We were looking at two different providers in the same group. One provider had horrible scores because he would get people in and out, like literally that 15 minutes. And then the other provider, people were frustrated because he doesn't see enough patients, but he had the best scores in terms of listening. He would sit there and give you all the time in the world. And patients felt like he really took care of them, listened to their concerns, educated them, right? I think that's a huge piece. We don't really have a lot of time to do that true education deep dive piece that I think a lot of people crave and want, but don't really know the questions to ask. And so when you're looking at scenarios like that, the productivity versus the quality of it, I think we need to do a better job at balancing those metrics. And so some things that happen behind the scenes, for example, is reimbursements, right? Like Medicare will send surveys to Medicare beneficiaries saying, where you explain your medications, your signs and symptoms, how well did your physician communicate with you? How well did your nurse communicate with you? And so I think there might be opportunity there to help make sure those two
tie incentives
and tie the incentives to the quality and the outcomes we want to see. Because a lot of times just from that system and organizational structure, those are some of the levers on the federal level that we can pull to try to shift. But I'll let you make a comment if you want.
No, all of that is exactly right. You know, and when you're talking about what do you do? So another resource that I'll throw out here to the crowd, if you've not, you know, because it goes back to my comment about knowing the territory and knowing the language of policymakers. If you've not yet read the Institute of Medicine, it was then called the Institute of Medicine, National Academy of Sciences. If you've not read Unequal Treatment or To Err is Human, I highly encourage you to read both of these reports, right? Because these are the most seminal works, the foundational works, I'd say, with respect to what health inequities are, what health disparities are, as well as the Heckler report, written by then Secretary of HHS Margaret Heckler in 1985. And she herself used to be a member of Congress, and she was a Republican. I'm going to actually get to the question, but I do want to make sure that I'm talking about these reports. So the report that I just named is the Heckler report, HECKLER, named for Margaret Heckler. You can just look it up. It actually has a longer title, but it goes by the Heckler report. To Err is Human, Institute of Medicine, and if you read nothing else, you must read Unequal Treatment, also by the Institute of Medicine. And in Unequal Treatment, there's an entire section that talks about bias, right? And let me just be clear: we all operate on some level of with some level of bias, especially when we are stressed out, or especially when we are heightened, right? You can think of any kind of scenario, and actually it serves the body well. Do not misconstrue me. I am not saying bias is good. What I am saying is that when it comes down to scenarios where you have to make very quick decisions, usually your brain is set up to respond to something that is associated with something else. That usually happens when somebody is stressed out. So if you're talking about providers who are burnt out, who are stressed out, in those scenarios, you have a lot of people who are not tapping into reserves, right? They may have spiritual reserves. They may have other reserves that really sustain them, help them to be a bit more resilient. But when it comes down to just biology, a lot of people are responding to something that reminds them of something else, and there's only one answer that could come out of that reaction, and that answer is based on a biased response, or rather could potentially be a biased response, right? So if you're talking about a stressed out physician who all day has been seeing really very hard patients, and all of a sudden their final client is a Black woman complaining of a headache. For whatever reason, they may be so stressed out at that time that they're only coming to one conclusion about what her headache is, and that's that. And I'm not saying that's right. I'm saying understand how that happens. And so when you then layer that on top of people's thoughts around race, people's thoughts around gender, people's thoughts around age, it's really hard to untangle, it's really hard to untangle the bias itself from what ought have been communicated by the provider. And so I say all that to say, you just have to understand that everyone does that to some extent, short circuits themselves. I don't know if you could hear all these ambulances. Lord of mercy, I hope everything is okay. People short circuit to get to the right answer. That can be harmful in medicine. It is often harmful in medicine. So what do you do for scenarios like that? There have to be, going back to your point earlier about mental health services, there have to be built-in processes within clinical walls and across different care systems to answer to to really care for the care provider, right? And if someone is working in an environment where that is not there, then they are not only doing a disservice to their employee base, but they're obviously doing a disservice to their patients. And I know we're short on time. I feel like we can talk about that part forever, Meagan. I would love to get your experience, with that as a nurse yourself, perhaps in the future.
No, 100%. And I was just gonna say 100% of what you said about the mental health of the clinician as well. So many times, and I think that there might be some incentive structures there. I've heard clinicians say, I want to seek services, but I'm scared of what it would do to my licensure, yes. Right? Mm-hmm. And so that's a whole conversation about clinicians and their mental health to make sure their cup is full so they can pour into someone else. But we are at time. And so I will say, a lot of people unfortunately committed suicide during COVID. And so yes. We really saw that has to happen. That has to be a destigmatized priority. 100%. And so thank you. Thank you so much for this conversation. I really appreciated it. I did see one more cute question that said, can you please repeat the report name? So it's being recorded and we'll get that information to everyone when it gets sent out. So thank you. Do you have any parting words for us? The final thing I'll say is, because this is also just a women's health conversation, earlier this week, the United States Preventive Services Task Force dropped guidelines with respect to breast preventive screening. And so for those who are women or people with breast on the call, now the screening guidelines say that women beginning at the age of 40 and every other year after, those with an average risk of breast cancer ought to receive a mammogram every 2 years. And that change is pretty significant, because the previous guidelines said that should start at age 50. But what we saw were Black and brown women dying way sooner in advanced stages of disease. So take a look at those guidelines, talk to your family members. And again, for those of average risk of breast cancer, starting at age 40, get your mammogram. Thank you so much. And thank you everybody for joining the call. Be on the lookout for MOMMA'S 2.0. The Congresswoman is super excited and we are partners in this fight together. So I will just say, I know the Congresswoman will say her office is open. So please let us know how we can be of service. Thank you, everyone. Thanks, Meagan.